Hi, it's a privilege for me to be here today and to be presenting on eating disorders complicated by other diagnoses. And it's very rare for eating disorders clinicians to meet someone with only an eating disorder because eating disorders co-occur with a wide range of physical and mental conditions. And my goal today is to offer you an overview of these and to try and explain how they work together, how they can be best understood, and how they can be best treated. What is comorbidity? It's the co-occurrence of two different mental health or physical medical problems. And I'm going to focus on those that are commonly found together with eating disorders. I won't be able to be exhaustive, but I do hope to give you an idea so that you'll be able to learn from what I say and also continue afterwards to learn more about your loved ones' comorbidities and how they can be best dealt with and best treated. Why is this important? I believe it really is, otherwise I wouldn't be here, for clinicians and also for family members to be knowledgeable about the broad picture of health problems with which your client or your loved one presents and not focus on one disorder to the detriment of the others and or de-emphasize another one because you're losing the whole picture. And in many cases, the different diagnoses are intertwined. They work together, they influence each other, and it's important to understand how. For example, a person with eating disorder and depression, it's really especially important to encourage them to improve their nutrition and their physical condition, which is always true, but especially with depression because depressive symptoms can be a direct consequence of malnutrition on the body and the brain, and often they lift with good nutrition and physical and mental stability. Now, this is not always perfectly true, and depression that lingers on after an eating disorder can make complete recovery very, very difficult, and I'll come back to that later. Recognizing and treating these comorbidities can improve the outcome for an eating disorder, and treating the eating disorder can improve the outcome of the other comorbid conditions. So understanding which came first and which developed together with the eating disorder and may lift with it is important. Now, you as family members are in a great place to tell others what you've seen and what you think was there before and what was not, because this can really provide insight and help the treatment. And I would even go as far as to say that it can be dangerous not to recognize and treat the other conditions, because we know, for example, that anorexia nervosa plus another mental disorder confers high risk for death. Okay, so if you know there are two disorders that need to be treated, treating them well can even save lives in some cases. Now, in order to treat comorbid condition, they need to be diagnosed accurately at the outset of treatment. So screening and intake interviews should be comprehensive, and they should include questions about a wide range of medical and mental health disorders and their relationship to the eating disorder. This information can be very helpful, and then the treatment team can make a plan, an individualized treatment plan for each patient that recognizes the eating disorder and the other diagnoses, and therefore increases the chances of recovery. Now I'd like to present some of these comorbid conditions, more specifically the comorbid medical and mental health conditions that come along with the eating disorders. Now, I'm a clinical psychologist and not a physician, so my specialty is the latter, but I really know that the medical conditions are so important to mention and to be aware of, so I'm going to overview them as well, and we'll have a look at that first. Now, some of these conditions are, of course, or most of them, in fact, if not all these, are direct consequences of the eating disorder because food is medicine. And it is hardly surprising that poor nutrition and binging and purging harms physical health. So Some of the complications are cardiac or heart problems, hormonal problems, abnormal glucose levels, low bone density, osteopenia, osteoporosis, imbalances in the electrolytes. And then we have gastrointestinal problems such as bloating, constipation, diarrhea, irritable bowel syndrome, heartburn, that often occur together with an eating disorder, and these can be misconceived as a cause instead of a result. So, I'm so bloated I can't fit anything else in. But in fact, this is also a consequence. So it's a maintaining factor, and it's important to get past and to, of course, fight with the bloating, because it's going to disappear most likely at some stage with improvement in the eating disorder. There are autoimmune diseases like type 1 diabetes, celiac disease, metabolic disorders such as type 2 diabetes that occur quite frequently with eating disorders. In this particular case of diabetes, it's really challenging, really dangerous, because insulin levels can be manipulated in the interest of the eating disorder to manipulate weight. And this is a terribly, terribly dangerous and often life-threatening situation. So it's really important to get good management of both those conditions together. Now let's move forward to the mental health conditions. Research shows us that a lot, like 55 to 97% of people with an eating disorder also receive a diagnosis of another mental health disorder. The most frequent mental health diagnoses that are associated with eating disorders are depressive disorders, anxiety disorders, and addictions. I'm going to say something about some of these, not all of them, because we don't have time, but I'm coming back to the issue of depression because it really is so common. It's really hard to find a person that doesn't have an eating disorder with some symptoms of depression. And that's true across the board for all the diagnoses of different diagnoses of eating disorders. And but the dance between the depression and the disorder does vary considerably. So, for example, let's take, say, Ingrid, let's call her, whose mood really plummeted and became very, very changeable when she developed bulimia. And this was at age 15. And she was caught early and helped back to health by her therapist and her family. As a result, as she approached her fully nourished state, her mood improved again. Her parents said her old chirpy self is back. And this was a positive case, but in some cases, mood can take quite a while to improve and stabilize, and it can also persist after physical health has been restored. There is, in fact, a high incidence of major depression in first-degree relatives of people with eating disorders, and the comorbidity of anorexia nervosa and major depression seems to be linked to genetic factors that influence both of the disorders. So around half the time, depression predates the onset of the eating disorder, and this is true also for other disorders such as anxiety disorders and trauma. So I'd like to tell you a little bit now about Hannah, okay? Hannah was 62 when I met her in an inpatient ward, and she was really skeletal. She was addicted to alcohol, and she had severe osteoporosis. She was after a very serious fall, and she had agreed for the first time to allow her anorexia, her severe and enduring anorexia nervosa, to be treated. This was the first time in over 40-something years of having the disorder. So this was dramatic. The thing is that thinness had been her lifelong pursuit and achievement. And she found that although she'd asked for help, she was enraged that her decades of investment and were just being taken away from her and sabotaged. And in our sessions also, we started to talk about things that were really real and significant to her, like her separation from her partner, long-standing partner, that had been so painful. And so now it was so much harder for her to deal with the pain, the emotional pain, than to think 24 hours a day about calories, food, weight. It was easier. but these eating disorder symptoms were actually regulating her mood and helping her to manage her emotions that are so difficult to face, so that Hannah actually experienced serious depression with the weight gain because it was very difficult for her. And after the inpatient treatment, she actually made a serious suicide attempt, which she survived and went on to do okay. And I'll come back to her in a minute because going down the disorders, we can see that addictions are also very common in individuals with eating disorders, especially bulimia. But Hannah had anorexia, and she would use the substance, in other words, the alcohol, for two purposes. First of all, to suppress her appetite and not, control her weight, but also they served a self-medicating function, so that every evening to numb the pain of her loss in the relationship, she would just drink herself to sleep. And one of the major benefits of the inpatient treatment for her was that she was able to give up the drinking completely. She never was able to completely give up the anorexia, but she did give up the drinking and really appreciated it. It improved her life considerably. Let's talk a little bit about post-traumatic stress disorder and complex trauma, because this is sadly a very common comorbidity. Now, typically the eating disorder will come after the trauma, either immediately or down the line. It could be weeks later, months later, years later. And it's a very tricky combination to treat. I'd like to tell you here about another patient, current patient of mine, with her agreement, her consent. This is 27-year-old Nina, not her real name, who was abused by a boyfriend and a whole gang of his friends for over 5 years from the age of 11. Now, several years after the abuse stopped, Nina developed an eating disorder, and it's oscillated somewhere between anorexia and bulimia over the years. She also has fully blown PTSD with flashbacks, dissociations, haunting her every day. And when she experiences extreme distress, she also dissociates to the extent that she becomes, in fact, her 5-year-old self, and her dissociations are not available to her. She loses a lot of time, so that these are separate personalities. It's a separate personality who actually does things that really embarrass her, and she would receive the additional diagnosis of a dissociative identity disorder, and also she would fulfill all the criteria, I think, for borderline personality disorder. This is somewhat of a question in professionals, and I would argue that the more appropriate diagnosis for Nina would be complex trauma, which is recognized in the ICD, but in the DSM, it would be PTSD, post-traumatic stress disorder, plus borderline personality disorder. It took us ages in our therapy to establish trust. And the first stage of our treatment was really devoted to developing trust and to try and create some safety for Nina in terms of her being able to nourish herself better, to harm herself less, and to calm herself when her stress levels rise. I forgot to say that she also self-harmed and so would have non-suicidal self-injury disorder. And therapy is really, really tricky because we started to work on her trauma. And working on the trauma causes ping pong because that triggers her symptoms. And her symptoms flare up again. And she harms herself and uses her eating disorder symptoms. And then, of course, she avoids talking about the trauma, so we can't touch that again, and we have to keep her safe. So there's a lot of work to do, but she's really motivated and things are moving along slowly, and hopefully she'll be able to relieve the really painful symptoms of both disorders. Now, we don't really have time for description or case presentations of the other disorders listed here and more, but just a couple of recommendations for therapy that you should be aware of. Diagnose and treat both disorders, all disorders. This is critical to recovery. Form an individualized treatment plan. build safety and trust in therapy, and that might involve staging the therapy, i.e. working on physical and emotional health and immunity before going on to some of the more difficult emotional work, and meet the clients where they are in their journey to health. So I'd really encourage you to learn whatever you can about comorbid conditions that you observe in your loved ones, so that you can support him or her as much as possible and find appropriate treatment. And I'd like to end by telling you about, by citing Gili. Now, Gili was a participant in a group that I facilitate, and this week we were discussing what they would like other people to know about eating disorders. This was in the context of World Eating Disorders Day, which is the day I'm recording on, and it won't be the day that you'll be viewing me on. But Gili said some things that were so wise, I'd like to share them with you, because in a way they say it much better than I can. So this is what Gili says. Even the best eating disorder treatment is fraught with difficulties and cause the other problems to surface, and I think that they should be addressed. It happened more than once that I was in the middle of really helpful eating disorders treatment, but as soon as I had suicidal crisis, I was kicked out of the system right then and there. And when I was trying to pick up the broken pieces in a psychiatry ward, there was absolutely no support for the eating disorder, which meant that most of the work I'd done with my eating disorder went down the drain. That just made me more suspicious, less trusting in the system, and less cooperative. I think professionals need to understand the complexity that these things go together. You can't put an ED in one box and suicidality in another. You have to see the patient as a whole person and agree to treat her with all her complexity. Otherwise, it's like a Band-Aid each time, and a feeling of failure and frustration each time that treatment doesn't work. So I really, really thank Gili for these words, and I thank you for being with me, and I thank F.E.A.S.T for inviting me.